My name is Sharon Peavy, and I'm the president of the California Club here in Laguna Woods Village, and we are so thrilled to have you all here today. I am going to introduce Terry Diener, who's in charge of our sponsorship with UCI Health. And they have been just wonderful sponsors to promote our club and to promote UCI with all sorts of fabulous seminars they've done here. They sponsor our dances and our PAC events and California Dreaming, and we are just so happy to have them part of our team. She's going to introduce our speakers today, and you're going to be thrilled to have them as well. So here is Terry.
Thank you, Sharon. I'm just so excited to be in Laguna Woods and to be very close to be part of learning about the community, spending time with you all, and bringing you some great educational programs. This is our fourth in the series, and then we have a fifth one that's more on Medicare. Things are changing, so that's what I do at UCI. I do a lot of Medicare information. I just want to let you know we have our new hospital finally opening on December 10th over there on campus in Jamboree, and we have an open house on the 15th, and we have information out there at the table about it, so you're able to do that. Thanks, Sharon. So we have two wonderful professors, PhD doctors with us today to do this lecture on cognitive healthy aging and cognitive compensatory training. Let me introduce them to you properly. It'll be a little longer than some, but I want you to be aware of their credentials. We have Michael Lopez, who's a PhD. He's a clinical neuropsychologist, the director of neuropsychology at the Neurology and Traumatic Brain Injury and Stroke Clinic in the Department of Neurosurgery, and assistant clinical professor in the Department of Neurology. Michael completed his internship at the VA Central Iowa Healthcare System and the Neurology Consult Service. Following this, he completed a 2-year neuropsychology fellowship at the University of Utah in the Department of Physical Medicine and Rehabilitation with a primary focus on neurotrauma, neurological disorders, and aging. Concurrently, he completed a 2-year rotation with children and adolescents with various medical conditions with a specialization in spina bifida. Michael conducts research related to traumatic brain injury and performance validity in his current clinics. He also focuses on multicultural assessment, particularly with Spanish-speaking populations, and conducts comprehensive psychological evaluations in Spanish in a newly founded clinic called the Neuropsychology Spanish Language Clinic at UCI. We have long titles and long names of things at UCI, can you tell? And I'd also like to introduce Haley Christensen. She also has her PhD in psychology, is a board-certified neuropsychologist and assistant clinical professor in the Department of Neurology. She obtained her PhD in psychology at the Wright State University School of Professional Psychology. Actually, a PhD in psychology is a Psych D, is what they call it. So if you're familiar with that at all, I wasn't, and I had to make sure I made you a full understanding of it for you all. And completed her internship at the Wallace Kettering Neuroscience Institute. She completed her 2-year fellowship in neuropsychology at the Sports Concussion Institute in Culver City. She is passionate about working with older adults who have neurodegenerative disorders and providing acute diagnosis to inform treatment planning. Her focus is on offering thorough assessment of patients' cognitive functioning to improve the quality of life of older adults with neurodegenerative disorders. Christensen's research interests include clinical trials in neurodegenerative disorders and examining cognitive markers that can be used to predict conversion to dementia in older adults. She is the director of clinical training for adult neuropsychology in the UCI Lifespan Psychology Practicum Training Program. Christensen is passionate about community service, and she and Michael are also part of the community outreach for the neurologic department's inclusion, diversity, equity, Anti-Racism and Social Justice Committee. Those weren't short by any means, but I wanted you to see what experience levels we're bringing today to you so that you can get a really good understanding and actually a very clear understanding of what's going on with these diseases and obviously the topic. Without further ado, are you starting?
All right, good afternoon. Thank you guys so much for taking the time to be here. I'm very excited to be at Laguna Woods. This is my first time here and it's really such a special and impressive place. So Dr. Lopez and I are here today to talk to you about healthy cognitive aging and cognitive compensatory training. So what we're going to start off with is I'm going to go through some different definitions of terms we all hear thrown around. I'm going to talk about different causes of cognitive impairment. And then Dr. Lopez will take over and he'll talk to you about some healthy brain injury, brain aging, and talk about what cognitive compensatory training is. So we've all heard these terms, right? Mild cognitive impairment and dementia. And they get thrown around and as I'll talk about in a couple of minutes, most people don't really have a great understanding of what these different things actually mean. So what mild cognitive impairment means is that there's cognitive impairment that's beyond what we expect from just normal aging, but it doesn't affect your day-to-day activities. So it doesn't affect your ability to remember to take medications, drive, keep track of appointments, things like that. We call it dementia when that cognitive impairment becomes so severe that you need help with those daily activities. So dementia is just the umbrella term that means the cognitive impairment is severe enough that it impacts your day-to-day functioning. But that does not give you any indication of what's causing the dementia. There are lots of causes. Alzheimer's disease is the most common cause of dementia in adults over the age of 65, but there are lots of different causes, which I'll get into a little bit. And I'm going to stress this a lot. Mild cognitive impairment and dementia are not part of normal aging, which is a common misconception and really stems from deeply entrenched ageist beliefs that we have in our society about what normal aging is. So MCI involves subtle memory and thinking changes that, like I said, are distinct from what we expect with normal aging. And about 12 to 18% of people over age 60 are living with MCI. 10 to 15% of those will develop dementia each year. And about a third of people living with MCI due to Alzheimer's disease will develop dementia within 5 years. And 42% of Americans say they worry about developing MCI or Alzheimer's disease, but over 80% of Americans in a study done by the Alzheimer's Association in 2022 say they know very little about what that actually means. And with the US population projected to rise from 58 million to 88 million by 2050, we're going to see a rise in cases of MCI and Alzheimer's, so it's really important for us to be able to distinguish mild cognitive impairment and dementia from normal aging in order to have early intervention and accurate treatment planning. So a lot of people worry about developing MCI or Alzheimer's, and 85% of people say they would want to know if they had signs of early Alzheimer's. But up to 60% of people indicate that they would delay or avoid seeing a doctor, mainly due to fears of misdiagnosis, or that they'll be given treatments that don't work, or they just don't want to hear bad news. Primary care providers are often the front line, so most people will go to their primary care provider and say, you know, I'm having some memory problems, what do I do? Yet only about 2/3 of primary care providers report being really comfortable discussing cognitive issues, and even less kind of comfortable diagnosing it. And you know, up until recently, with the discovery of biomarkers, blood-based biomarkers, cerebral spinal fluid biomarkers for things like Alzheimer's disease. Alzheimer's disease is something that we had to diagnose as a probable condition. So we didn't know until after death, and we could look at the brain, does that person actually have Alzheimer's? But now we have indicators of it. So there are different trajectories in someone who is, on the normal aging path versus MCI versus dementia. So with normal aging, there's slow, very subtle changes that remain within normal limits. So if you had cognitive testing, your scores would be average or above compared to other people the same age as you. That's normal aging. There might be kind of processing speed or efficiency of processing information tends to decline a little bit with age, but definitely not as much as people tend to think. And daily life and independent function are preserved, so none of these difficulties interfere with day-to-day activities. With mild cognitive impairment, you'll see a decline that's more than just normal aging, but most people are still functioning well. There are different subtypes of mild cognitive impairment. So amnestic mild cognitive impairment often precedes Alzheimer's disease, and that's characterized by impairment in memory, so rapid forgetting of new information. With dementia, we see it as more progressive. It's more of an accelerated decline that interferes with daily life and tends to drop off later in life as well. And when we're talking about cognition, we're referring to more than just memory, right? We often think about memory, but cognition involves a lot of different things. So if you come and see someone like me or Dr. Lopez and have your cognitive functioning evaluated, we evaluate all parts of your cognitive functioning, not just your memory. We want to look at your attention. Is there something that's impacting your attention and you're getting distracted more easily, or you can't focus? If you can't focus, it's hard to learn and remember new information, right? And as I'll talk about in a minute, memory consists of different stages, and it can fail at any point along the way. So a problem with attention can look like a memory problem, but really the information's just not getting in because you're not able to focus on it. Processing speed, as I mentioned, is one of the things that we see decline with age. And this is how quickly your brain can process information, make sense of it, and respond, kind of like the reaction time of your thinking. Your language skills, not just your verbal expression, but also your comprehension, reading ability, your spatial reasoning, helps with things like, reading a map, directions, things like that. Your executive functioning is like the brain's manager, and this is like your problem solving, your reasoning, planning ahead, staying organized. And then also sensory motor functions, so balance, coordination, strength, vision, hearing. All these things interact with one another to help you make sense of the world around you. So what's normal with age? Like I said, the primary thing that declines mildly, but like I said, still within normal limits compared to other people the same age as you, is speed and efficiency of information processing. Memory consists of three main stages. There's the initial encoding, so you have to get the information in, and then your brain has to store it, and then you have to be able to retrieve it. So different things will affect different parts of memory. So Alzheimer's disease is a storage problem. So the information, or the brain doesn't store new information properly, so you forget it rapidly. And how we know that is because if you give someone with Alzheimer's disease a clue or a cue, it doesn't help because there's nothing to cue because the information isn't stored. Alternatively, other things can affect retrieval. So the information's in there, but for some reason, there's just trouble getting it out. But if you give someone a little hint or something, that helps. So there might be, some less efficient recall with normal aging, but cueing helps. But it's not like the rapid forgetting that we see in something like Alzheimer's. There might be mild inefficiencies in certain aspects of problem solving or language, or a mild decline in visual spatial skills, which is often due to things like cataracts or loss of visual acuity. So I wanted to mention ageism because today is actually National Ageism Awareness Day. I put up a few quotes from Ashton Applewhite, who's one of my favorite ageism writers. She has a fantastic book called This Chair Rocks, a manifesto against ageism, and I encourage you to read it if you're interested. She's amazing. But a lot of our thoughts about what aging is come from these deeply entrenched beliefs that are very ageist. There's this notion that getting older necessarily means you're going to be cognitively impaired, which is absolutely not true. Not all older adults are forgetful. There can be mild, occasional forgetfulness, no matter what age you are, right? I forget things fairly regularly. I do things like leave my keys in strange places. It doesn't mean that there's something wrong. There's a stereotype that older people can't keep up or learn new things. That's not true either. Maybe learning is a little less efficient, maybe it'll take a little bit longer, but it certainly doesn't mean that you can't learn. And there's an idea of stereotype threat. So that means that when an older adult worries about confirming negative stereotypes, their performance on memory or other cognitive tests can actually decline, which kind of artificially magnifies the age differences. So these are some of the stereotypes that are pretty entrenched in our belief system, but are absolutely not true. So a common question that I often get from people in clinic is, how will I know if something's wrong or if this is just normal aging? Or I want to know if I'm normal compared to other people my age, or if I have signs of dementia. If like I said, occasional forgetting is very normal and happens to all of us regardless of age. If it's becoming so frequent that it disrupts your daily life, that's a sign that maybe there's something else going on. If people are telling you that you've already told them that story 5 times, or you're asking the same questions over and over again, or something like that, oftentimes it's friends and family members that will notice these things more. So if someone mentions that to you, it might be a good idea to get checked out. Making occasional errors, forgetting to write the date on a check, or doing something like that once in a while, totally normal. If all of a sudden, you can't manage your bills and your power's getting shut off, things like that. So as you can see, the consistent theme of when to be concerned is if it's impacting your day-to-day life regularly, and yet there's negative consequences. Having difficulty because you got a new phone or you need someone to help you figure it out, that's normal too. If you can't do things that are routine or familiar, all of a sudden the washing machine that you've had for 10 years, you can't figure out how to use it anymore, or things like that. And sometimes even before the onset of cognitive impairment, we'll see changes in mood or behavior. So people will become a lot more withdrawn or depressed or anxious, which, certainly if that's happening, it doesn't mean that you're about to develop dementia, but it's something to get checked out. But certainly preferring to stay home once in a while rather than socializing is normal. I know I do. So as I said, things that disrupt your daily life, then it's a good idea to get it checked out. So in terms of the different causes of dementia, as I mentioned, for adults over the age of 65, the most common cause is Alzheimer's disease. But actually in autopsy studies, we find that most people often end up having a mixed pathology. So that means when they look at their brains, there's evidence of Alzheimer's disease. There might also be some vascular changes. There might be a few Lewy bodies. So it's often due to more than one thing. Vascular dementia that occurs just as vascular dementia and not part of something else is about 5 to 10% of cases. And this is often due to strokes or in people that have a lot of cerebrovascular risk factors like heart disease, hypertension, high cholesterol, things like that. Frontotemporal dementia tends to occur in younger people, so typically ages 45 to 60. This often presents with, there's different subtypes, but it can present with behavioral changes or language changes. And then there's other diseases like late or hippocampal sclerosis that look like Alzheimer's disease. They cause rapid forgetting, but they're not due to Alzheimer's. And the key point here is that more than half of people diagnosed with Alzheimer's actually have mixed dementia, which is particularly common in people over the age of 85. There's also often multiple pathologies. So there are lots of things that can cause cognitive problems besides a neurodegenerative disorder or dementia. Poor quality sleep. We've all had nights where we've had bad sleep and the next day you just kind of feel foggy and you can't pay attention and you just feel slower. That's totally normal. If you have chronic insomnia, you're waking up every couple hours. A lot of our memories are consolidated during sleep, so if you're not going through the regular sleep cycles, that can really have an impact. So focusing on getting good quality sleep is really important. Doing things like, a lot of people will say, oh, well, I sleep better if I have a glass of wine before bed. But unfortunately, alcohol interferes with the regular sleep cycles. It gets converted to sugar while you're sleeping and it'll often cause early morning awakening. So even though it makes you feel like you can fall asleep, your sleep is actually worse. Anxiety, depression, other things related to mood are a very common cause of cognitive problems and something that Dr. Lopez and I see in clinic a lot. Often the question is, is my memory problem due to dementia or am I depressed or anxious? Things like chronic pain, if you're grieving the loss of someone, all these things impact your cognition. Untreated obstructive sleep apnea is another really common cause of memory problems. So even when you stop breathing for a few seconds, which is not even something that necessarily will wake you up or that you even notice, people often think sleep apnea, you're waking up gasping for air, which is not necessarily the case. But all those times that you stop breathing, your brain stops getting oxygen and that can affect your cognitive functioning. So it's something that's really important to treat. And I know CPAPs are hard to get used to, but it's a really important thing to be aware of. Other metabolic or endocrine disorders can affect cognition, so like thyroid disturbances, low vitamin B12 or folic acid, anemia, complications of diabetes, all those things affect your cognition as well. So typically when you go to the doctor, one of the first things they'll do is order lab work and see, is your thyroid level off? Is your vitamin B really low? Those are things that are easy to address. Sensory deficits. So I see a lot of people that are having hearing problems. Well, if you don't hear something, of course you're not going to remember it. That doesn't make sense, right? So that's something that's also easy to fix. If someone tells you that you seem to be missing a lot of things, maybe it's good to see audiology and just get it checked out. Other kind of infections or certain medications can affect your cognition, like particularly in older adults. There's something called the Beers criteria, and they have medications that we know kind of older adults are more sensitive to or might work a little differently. So all of those things can impact your cognitive functioning. So as I said, occasional memory lapses are totally normal. Sometimes I'll see people in clinic and they're like, oh, I left the stove on once, so I knew I had to get checked out. Leaving the stove on once, if you've done that once in the past 5 years, totally normal. I've done it at least 3 times. But is it increasing or do you have consequences because of it? Is it a pattern? Like I said, often people, the first step is to go to your primary care doctor and express your concerns. They'll often order lab work to check some of those reversible causes. And then you might get referred to a neurologist. And so at UCI, our memory disorders neurologists, oftentimes their workup consists of, they might order a brain MRI or other types of neuroimaging, and then you might get referred to someone like myself or Dr. Lopez for a cognitive evaluation. So depending on what your needs are, the kind of symptoms you're having, that will kind of determine, what your workup will consist of. They might refer you to sleep medicine because they suspect that you might have sleep apnea, or maybe you're anxious or depressed, so they want you to see psychiatry. So before I hand it over to Dr. Lopez, in terms of kind of mitigating your risk for cognitive impairment, some things are modifiable and some are not. So the number one risk for something like Alzheimer's disease is older age. We all age, we can't do anything about that. Also your genetics and family history, also things you can't do anything about. But modifiable risks are things that we can have some control over. Obviously, these interact with social determinants of health, so not everyone has access to clean, healthy food or clean air. So some of these, are modifiable to some extent, but not others. And as I mentioned, the population is getting older, so we're going to see more cases of different types of dementia, particularly Alzheimer's disease. And so I encourage you, there's a lot of information out there on the internet, and it's hard to know what's right or what you should listen to. There's also a lot of pseudoscience. So, sources like the Alzheimer's Association puts out a lot of really good, high-quality research. Other community organizations like Alzheimer's or OC, their websites have reliable, accurate information you can trust. If you go somewhere and someone's trying to tell you, if you take this $1,000 worth of supplements every month, I think your memory's gonna get better. Unfortunately, a lot of dietary supplements are not FDA regulated, so you don't know what's in them. They can put that there's 100 milligrams of something, but there's no regulatory body to make that accurate. So oftentimes, you're just wasting your money, and there's a lot of false claims and false research. So if you're looking at something, try and see if you find a supplement and they claim to have done a study that shows that it works, who paid for that study? Was it the company themselves, or was it an independent company? And I think, going somewhere like UCI, where a lot of the doctors are also doing research, I think is great. A lot of these big health organizations, because a lot of the doctors are doing research, they're up on what the latest research is, they have no motivation or incentive to tell you to spend thousands of dollars on some unproven treatment. So I think if you're not sure where to turn, starting with a big academic medical center like UCI is a good place to start. Not that I'm biased at all. Great, thank you very much. I'm going to turn it over to Dr. Lopez.
Well, thank you, Dr. Christensen, for a great presentation. And my piece is a question that we get all the time. I had my cognitive evaluation, and I got a diagnosis. Now what do I do, right? What do we do about getting a diagnosis, and how do we do treatment? If I don't want to do infusions, or if I want to just do something that feels comfortable to me. And that's what cognitive compensatory training is. Now, it is brain training, all right? We focus on skills that can help you with different aspects of your thinking. So that might be attention. That might be working memory, which is something like holding information in your mind. Imagine like doing a math problem, something like this. Flexibility in your cognition. And of course, we focus on memory as well. So to be eligible, usually we have a diagnosis of mild cognitive impairment. I put TBI up there, which is traumatic brain injury. Sometimes you can have a traumatic brain injury and have some challenges. So we do some treatment to help you with that, to help you recover some of the skills that you might have lost because of that injury. Now I want to focus here a little bit on compensation, rehabilitation, and training. There's a lot of different things out there. And usually when we do rehabilitation, it's usually when you're out of the hospital or right in the hospital, okay? You're trying to get home. Maybe you had a fall and they're teaching you all these things to get back, right? Now when you're back, you have an evaluation and maybe there's some things that are still there. Then we do compensation, right? That is what I do. That is the thing that I try to focus on as much as possible in the clinics. And then there's training. Training is the things that you have on your phone. Luminosity, playing word puzzles, Sudoku, those types of things. Those are things you can do on your own and with a partner if that's something that you choose to do. Okay? It's important to know the difference because they're all somewhat helpful, right? But they all have a specific purpose on when you do them and the timing of it as well. Okay? Now, cognitive training is about 6 to 8 weeks. It kind of depends on the clinic and it depends on what you're looking for. We've done a little bit of an adjustment within my clinics to try to make them a little bit longer because we find them pretty helpful. Patients like to come. We spend about an hour each week together. Sometimes it's every month, sometimes it's every 2 to 3 weeks. It just kind of depends on what your needs are. And we're trying to grow our clinic to be group so that we can make them a little bit longer, as I'll tell you a little bit why later. But group can be a little bit longer and it gives you support, right? Other people who might be having the same challenges that you might be having, what are they doing? How are they compensating for things? They might have skills that I don't know. Right? They might have this new tip that they're using that's been helpful for them. And that allows us to sort of disseminate that information to other people. Okay? And it's for family too. So if you have a family member who wanted to come and attend and learn a little bit about it, we encourage that. We actually prefer that because they can help you at home when it's an individual session. So if you're there and maybe you are having memory challenges, well, they can help you practice at home. There's a lot of practice that goes into this and a lot of things that we teach with homework, unfortunately, but fortunately, homework can be fun and helpful, that you do that family can help you with. Okay. So this is an example of some of the things that we do. Right? So here is just a little sheet. On the left-hand side, you're going to see one that is related to traumatic brain injury. For older adults, the most common reason you might get a traumatic brain injury is because you have a fall. Right? You have a fall, it can be ground level, maybe getting out of bed, maybe getting out of the seat, or maybe a car accident or something. So we'll go over that. Right? We talked a little bit about organization. We have specific sessions that focus on different things. And on the right-hand side there, you're going to see an example of what might be a lifestyle strategy. Eliminating alcohol, if you're drinking a lot of alcohol, those types of things, eliminate smoking. And then we go over these types of compensatory strategies as well, like deep breathing. We move on after we kind of give you an overview, and we do exercises like this. So on this page, you're going to see sort of word lists. And what we do is we try to teach you how these are associated. So imagine that you're working on this word list, and you see the word closet, and then you see the word coat. We might practice, okay, let's associate what might go in the closet. Well, a coat. And I will read you all of these words, and we'll come up with associations to help you remember. Now, it seems easy in practice, but when we're doing it in session, it's actually quite complicated because you don't have this in front of you. I have it. And I get to help put you through this, and we work together so that you can learn these tools and tricks and tips. This one's a little bit more challenging. This is called directive detective. And so let's say that you had some challenges with working memory. Now, if you look at the packet that you have, it's kind of hard to see, but what this does is really complicated directions. So if somebody were to tell you, well, I need you to make a left on this street, then you're going to stop at the second light, and after that, what I want you to do is you're going to find the Starbucks that's on the corner, and then there's a McDonald's, but that McDonald's particularly, their lights aren't working, so you've got to find that. That's kind of what this does here, right? And you've got to figure out exactly what we're working for. And the purpose of this is to train your brain to work the muscles that it needs to be able to get to the answer. Okay? The last one here is, let's say that we're having some language challenges. And we've tried to have you rearrange and come up with different items to look up.
Speaking to the mic.
Sure, I apologize. So if you're having some language challenges, we try to teach you some skills to reorganize different words. So the first one I always have trouble with, where we say, well, what's another word for taste, right? And we give you part of a word and then some other letters. Now this is really helpful, again, in reorganizing information that you see and coming up with the correct answer. So in this case, the answer would be flavor, right? But it can be challenging, and it gets harder and harder as we go along with trees. These are sort of the basics that we talked about. And each of our lessons builds upon the one previous. So we start easy, and we get harder and harder and harder to push you to your limit. That's a lot of the things that we do in testing to find what that limit is. And once we find it, then we kind of focus in and hone in on what we can do to be helpful. This last one here is a little bit of what Dr. Christensen was talking about of these strategies. So she mentioned at the beginning, if you're not able to pay attention really well, maybe we just didn't get the information in, and if we're able to get the information in, maybe we'll have a little bit of memory. And on that box there, it's one thing that I think is super important for us to utilize. It gives you sort of a breakdown of what can be helpful for memory. So as you see there, if you only read something, you're only going to remember 10%, and it goes up from there. If you hear something, it's 20%, but the best one is if you're teaching something. So if you know a skill, you know it really well, teaching it to others will help it be solidified in your memory. We teach you these skills, we go over them, and that's why this keyword of practice is important. We practice a lot in session, and you practice a lot at home. Cognitive training is based on a lot of research. We know that it works. We know that it works for a couple of things. It helps you improve your skills when you're at home, both with your thinking abilities, but also with what Dr. Christensen talked about, which was your activities of daily living, right? Remembering to take your meds, remembering to pay the bills, or being able to pay for things when you're in the stores. It also shows a lot of support for family, right? Neurodegeneration and these types of diseases, they're family diseases. Even though it impacts one person, that doesn't mean that that's the only person who's having challenges, right? So with cognitive training, it allows us to support the family as well. It gives them the needs that we can do for them. It's goal-oriented, right? We have goals. We set goals for you, and you set them for yourself. And we try to accomplish those, okay? I'll show you a little bit about how we do that soon. But I do want to point this out. It does not prevent cognitive decline, okay? Unfortunately, it doesn't. But it can improve the skills that you have at your disposal to use when you need them, all right? Whether that's writing lists, whether that's communicating with others, that's the goal. We talk a little bit about these three things as well: sleep, diet, and exercise. Dr. Christensen talked a little bit about sleep in terms of obstructive sleep apnea, if you're having a bad night's sleep. We talk about how that might be better. What's your sleep like? We have a couple of tools to help track. So I'll come in and we'll talk a little bit about, well, tell me what your sleep is like. And maybe your sleep is really erratic, but you don't know. And you say, well, I think I go to bed at 10. Sometimes I wake up at 6. But maybe that's not true. Maybe you actually go to bed a little bit later and you wake up at 6 and sometimes at 8, maybe at 10. So we get you on a really good schedule. So you're able to see what that's like and make the adjustments that you need to help you sleep a little bit better. We talk about different types of diets. So maybe all of you have heard about the Mediterranean diet. I'm going to talk to you more about that in a little bit. But there are other options, right? We talk about other options here. As you can see here on the screen, it's the Mediterranean diet. We have the African heritage diet, the Asian heritage diet. There's a lot of different diets that can be useful that cover the same things that are important for your health. Here's just a little pyramid of the Mediterranean diet. I won't spend too much on this because I'll talk about it in a little bit. And then the big one that I like to focus on the most is being social, okay? Being social is a really important aspect of just being human, but also as we age. When we had the COVID pandemic, a lot of us were isolated, right? And that isolation can be really detrimental to our physical health as well as our mental health, but it's, ultimately it affects our cognition. So I focus a lot on trying to improve that aspect and to help you come up with a plan to make your social network larger. Now, if you see, it can be anything. It could be gardening, it could be playing cards, it could be spending time with family. But the most important piece of it is to be as social as you possibly can, right? Now, I want to talk a little bit about a couple of things. So let's talk about the Mediterranean diet. Why does it work? What does it do? What does it really mean? And really, the Mediterranean diet has been shown to lower the risk of cognitive decline. Okay? It might reduce your risk of mild cognitive impairment, but it plays a really critical role in reducing risk. Okay? The key factors of the Mediterranean diet are what we call this anti-inflammatory nutrients, right? Basically bringing down the inflammation in different areas, whether that's in your brain or your body. Everybody has the question, I have that question, well, what is that? Right? What are anti-inflammatory fats? Right? They talk about fruits, healthy fruits, nuts, omega-3 fatty acids, fish, those types of things, and vegetables. A lot of vegetables that can be really helpful to reducing inflammation. Whole grains can also be really great. Right? That's why it's really at the base of that pyramid that I showed a little bit earlier. And extra virgin olive oil is a big part of the Mediterranean diet. Okay? This helps contribute to the overall brain health because it's got a lot of what we call monosaturated fats. Okay? That's a really important thing for your brain. So that's why the Mediterranean diet is really backed by research. Right? It really shows, even people who have Alzheimer's disease, they see an improvement in their abilities. It's a very small improvement, but it's significant. It shows that, yes, it can improve. That's why this diet has gotten a lot of support in the media and in news, because it works, if we're able to. But there are some limitations. And I see there at the bottom, it says the duration and timing. It might matter. Right? We're still learning. It might matter when you start this diet. If you started it your whole life in terms of midlife to later life, it could matter if it makes a difference. But the most important thing is to start. Right? If you're not eating healthy, if we're focusing on eating a lot of fast food, those types of things, the quicker that you can start a healthy diet, the better. That's the key I want you to take away from this. Okay? Yes. Regardless of when, just to start in general. Socially active. Right? Being socially active can slow cognitive decline as well, all right, by a lot. So the more socially active you are, we see that it slows decline by about 1/4. Okay? That's a pretty significant amount of decline, or lowering the risk, I should say. And the social relationship actually really matters. Okay? Just being social is a good thing, but there are 3 parts. There's structure, there's function, and then there's a combination of the 2. Okay, so I want to break that down for everybody. Now, having a structure of social is really the quantity, how much and how many, and the organization, right? What does your social network look like? I'm going to use the term that they use here in the research, which is kind of use it or lose it. Right? If you're not being social and you're not able to build that skill, it's going to go away and you're going to feel a lot more lonely. And again, they talk about the COVID pandemic. It's a really, unfortunately, good model of what social isolation can do for everybody. So focusing on the structure, how much and how big your social network is, and then the function, which is the quality and the support you get from others. If you have a social network and that social network is rude and mean and you guys are just really nasty to each other, okay, let's not do that. Right? That's what this function means. Instead, we want a positive social network. People who build us up, people who are supportive of who we are as people, and support our dreams. Right? Family can be that way. Sometimes they're not, but sometimes, and a lot of times they are. But your friends can also be that way. Okay? And a combination of these 2 is also really important. So the network size and the relationship quality. The better that the size is, the better the quality, the better the support. Okay? Now here, in a community-based cohort, so some place like this, like Laguna Woods, on average, the most socially active individuals, which is about 90% plus, right? They're really, really social. They experienced only 1/4 of the rate of decline to those compared to people who were isolated. Wow. So being in a community is a really great thing. It's a really great thing for you to be in. But take part in the activities. Go and talk with your peers. Go and talk with your friends. Make sure you're making the time to do so. Now, exercise. Exercise is always one that I think we fight a little bit, right? What does exercise mean? What do you mean I got to do exercise? I don't really like doing that. but some people really enjoy it. But it's a constant discussion because it can be anything. I like to say anything is better than zero. So if you're walking 5 minutes a day and that's all that you can do right now, do it instead of staying at home, okay? Anything is better than zero. And it can be both physical exercise, like walking, maybe jogging, riding the bike, something like this, or it can be resistance training, right? It can be yoga. It can be something like low impact, something, okay? But we see this benefits for reducing your risk of mild cognitive impairment. And so it says moderate to vigorous aerobic exercise can be beneficial. At the high end, for individuals who like to exercise a lot, we usually say about 5 hours a week shows you the most substantial benefit, okay? About 5 hours a week. 2.5 hours to 5 hours is about moderate benefit. 1 to 2 hours per week is a small benefit, right? And then, like I said, anything is better than zero, okay? Like I said, resistance training can be really helpful. And some people respond to it better than others. You know, maybe you have some physical limitations that you can't actually do exercise. And that's why we really support you talking with your physicians and coming up with a good plan. There's something that we can do together and come up with a really good plan within our training sessions. We try to work really closely with your primary care physicians to come up with a plan to support. And we usually are able to find something that is positive. The benefits also might differ from your baseline cognitive status, okay, and genetic risks. Okay, if you have a lot of risk factors, for example, heart disease, you know, there's other things that might be big risk factors. We try to modify as much as possible and focus on the other things like social aspects of cognition as well. I think I put a little picture here. Another aspect and another area that we focus on is mindfulness. Has anybody heard of mindfulness? Has anybody heard of meditation? Now I'm sure they could be the same thing. I don't know, right? But they're different, all right? They are a little bit different. Okay, meditation and mindfulness, we asked that question, what was the difference between the two? Meditation is usually sitting, closing your eyes, trying not to think about anything. Right? You're just quiet, peaceful. Mindfulness can be a little bit different. And the way that we describe mindfulness within treatment is focusing on the present moment, okay, while you're here. So all of you are in this room focusing on the lecture that we've been giving, focusing on the slide, and you're here now. Maybe things are coming into your mind, oh, you know, I gotta call this person as soon as I'm out here. I'm done here. I gotta let them know how funny Dr. Lopez was. But you're not being present, right? And so with mindfulness, that helps us attend to the information that we're being given. Now remember, the first thing with memory is attention. If we can focus, the better off and the more likely we will be to get that information in. So we teach mindfulness. But not everybody enjoys that type of mindfulness. Some people, like myself, I like to be active when I'm mindful. I like to be doing things. I like to walk and focus on that. So mindfulness can also be an active activity. While you're out on a walk, you focus on how am I feeling? What's my breath like? What do my feet feel like? What does the air on my skin feel like? And that puts you in that present moment. It keeps you focused on one task instead of divided. So mindfulness has shown some support in a lot of areas. It's shown support in improving attention, in improving your long-term memory, and improving your visual spatial skills, so using your eyes to make decisions. It also has shown improvement in your hippocampus. Your hippocampus is where your memories are stored. So the more often that you can practice being present in your daily life, the better off that you will be. And I like this little graph here. Okay, so is your mind full or are you being mindful? It's a nice thing to think about when you're having some thoughts, right? Well, what am I thinking about? Your mind might be full of garbage. And instead of focusing on that, let's take all of that stuff that's bothering us, all that garbage, all those people who made us really feel bad that day, all the things that have just a struggle, and let's be mindful and be present in the moment that we're in. This is something that's new in the clinic that we try to focus on. It's called value-based living. Value-based living is an important part of our life. As we age, our values change. There's difference between goals and difference between values. Goals are something that you can go out and achieve, right? Today, I'm gonna go walk 5 miles. I have achieved that goal, I'm done. A value isn't really like that. A value is not something that you can fully achieve. It's more of a way of living. And I like to use the example of bravery. You don't go and say, I've achieved bravery. I've been fully brave, that's it. Instead, you might do something that you're fearful of, but you're still going to do it because you chose to be brave that day. And with value-based living, we see that it can lower the psychological impacts of anything. It can lower your risk of developing dementia, but it improves your purpose in life. Okay? A value-based living program, particularly here in the Laguna Woods, you're higher psychological well-being over time. We do this assessment in clinic later on in our treatment. When we age and things change, our values change. They might not be the same as they were when you were 50, when you were 40, when you were 30. And we often neglect that piece of our life. We neglect having to go and reevaluate what's important to you. And when we get a diagnosis of something like mild cognitive impairment, that's a change. And we have questions. What does that mean? What's it going to mean for the rest of my life? Am I going to decline? What's it mean for my family? What's important to me? That comes last. So we focus on bringing that to the front, to focusing on what are the motivations you have now? Is it travel? Is it to be a good husband or wife? Is it to focus on exercise? Right? We focus on values to support you. The psychological well-being is really closely linked to being healthy, lower morbidity, which is meaning like lower death, and longer survival among older adults. Particularly, this study with Portuguese individuals living in a community, okay, it usually counteracted a downward trend. To live the values that you have. If you're living your values, the downward trend of feeling like you're not feeling good is actually subsides and stays stable and improves. Great, Dr. Lopez. What do I do? How do I cultivate a value-based living? And we want to clarify those values. So we go over probably 80 different types of values. It's a lot. It's not just one session that we do it. We do it as an individual, and sometimes we'll do it if your partner comes with you or a family member. We do it as a couple. Right? Maybe your values are a little bit different right now, but I guarantee that a lot of them are shared. So we focus on that to get everybody on the same page. We talk about SMART goals too. SMART goals, SMART just really means they're specific. We can measure them. You can achieve them. Right? They're relevant to you, and they're time limited. Right? They're time bound. So it's not a long-term thing. Then we track them. Okay? We track them to make sure that you are able to accomplish the things that you set out to accomplish. So we might keep a journal and I say, well, what was your goal this last week? Did you act in line with your values? Let's look at the bravery. Well, I was fearful of going to the store and buying something because I was afraid that they were going to judge me or whatever I said. Right? Well, what if your value was, well, that's what I want to do. Did you live that? Did you go and do that? And we check it to see how things are. We engage with other people. Right? Now, this might be teaching younger individuals something. Maybe volunteering at a place that you enjoy volunteering at. These roles offer meaning. They give us a connection, and it's sort of reciprocal. We enjoy human connection. All of us do, so it's a reciprocal thing for us as well. We combine it with other protective factors like exercise, social activity, diet, all right? And then we adapt. Sometimes things change, right? We got to adapt to the circumstances that we're at. And the benefit of being in a treatment program like this is to help us adapt. Maybe something happens in those 6 to 8 weeks that we're together, and then we got to adapt. All right, what can I do? How can I make this better for me in the short term and the long term? We try to embed the values in social and community contexts. So this is just a fancy word of saying, well, let's join a book club. Right? Let's volunteer with those organizations. Let's do some social causes. And then one of the things here I talk about is acceptance and commitment therapy. It's a different type of therapy that really is the focus on value-based living. And the last thing that I think is really important to recognize and to mention is routine. Routine and reminders are extremely important. There's a lot of things that we can do with the phone, right? iPhones, sometimes they can be complicated. We got a new phone that we got from someone else, and we're trying to figure out how to use that. We teach you how to put things on that calendar. We set that up for you. We work together to make your life easier and to make you more successful in your daily activities as well. So is cognitive training for you? Is it something that you're interested in? If you have cognitive decline, if you've been diagnosed with mild cognitive impairment, if you've had a traumatic brain injury, or any other thing that is impacting your cognition, then yes, it is for you. I think that it can be really helpful. The materials that we use are in the public domain. Okay, it's called CogSmart, if you see here up at the top. It's developed by a wonderful neuropsychologist by the name of Elizabeth Plumley. And the CogSmart protocol we've adapted for UCI. The CogSmart protocol was made at the VA, right? So the VA was a big proponent of this type of treatment, and it works really, really well. So if you are interested to see what things might be covered within the cognitive training sessions, you certainly could go on here and take a look. There's manuals for you, there's manuals for me, and all she asks is for an email that you get that information sent to you. At UCI, we provide this for MCI and TBI. Oftentimes, and depending on the patient and depending sort of the needs of the individual, sometimes we'll provide it for other services as well. But there is, unfortunately, some tough news, is that it's only me right now. Okay? I'm the only one doing this over there right now. Dr. Christensen has been nice enough to help me with a few cases here and there. But it is a service that is still in development. We're still growing the service. And right now, it's typically only at our new Irvine office. I do see a few cases in Orange, at the Orange Hospital. From here, Irvine's a lot closer. And it's usually on Fridays only. But we're trying to build it. That's the benefit of the group, right? And think about what we talked about as being social. Having a group there to learn skills from other people is excellent. Right? So we're trying to transition to groups so we can see more people. But we're also hiring. Right? We're trying to find other people who can help us deliver this service. Right now, my wait list is pretty long. It's about 4 to 5 months, which in the grand scheme of things is short, but we want treatment as fast as possible. Right? We really want to have as many people come to see us to benefit from the techniques that we teach. So we're working. I'm working to try to get us a little bit more feasibility and availability. And of course, if you have questions, I'm happy to answer them and take them later on today. So I'm going to pass it back to Dr. Christensen really quickly, and she's going to talk a little bit about some of the research that she's doing in her clinic and a little of other important things that she offers as well. Thank you.
So up here is the number for UCI Neurology. You can find out more about our UCI Memory Disorders program online at this website as well. A resource I wanted to make you aware of, I'm actually a volunteer with Alzheimer's OC, which provides a number of amazing services for people living with Alzheimer's and other types of dementia, as well as their families and caregivers. There are numerous support groups. I facilitate a once monthly support group on the 4th Wednesday of the month at 6:30 on Zoom. I would love for anyone who's a caregiver of someone living with Alzheimer's or another type of dementia to join us. It's a great place for you to connect with other caregivers, so there's the information for that. I'm doing a study looking at people who are being treated with the new drugs for Alzheimer's disease. I'm not being paid or anything for this study. I'm doing it because I want to see how well these drugs work in a real clinical population compared to how they worked in the clinical trials. So it involves collecting blood samples and doing cognitive testing before initiation of treatment, after 1 year, and at 18 months. So if you or a loved one are being treated with either of these drugs, which are lecanemab or donanemab for UCI, then contact me if you're interested.